Waiting for one को मैं कहाँ रह रहा हूँ? शुरू में वहाँ पे भी पब्लिक ट्रांसपोर्ट नहीं है।
डॉक्टर आमिर आप शुरू करो दोबारा कर दें। मैं स्क्रीन शेयर करूँ। ब्रॉडकास्ट आया
नहीं सर, वेटिंग है। Second day in the video possible.
कर दिया सर प्रोजेक्ट में। उसमें एक आया था अभी कि आपको खुद स्टार्ट करना पड़ेगा। शुरू कर अरे सोचो नहीं ना, शुरू कर। जो भी आएगा वो ज्वाइन करे।
कोविड हो गया वो ओवर प्राइस हो गया।
तुमने अपना जूम से करा होगा।
बैलेंसिया काउंटी शुरू कैंडल लाइट के बाद बताना। ये नहीं है सर, कैंडल एक वाला चावला से थोड़ी अच्छा
बहुत नमस्कार।
Traffic was so stupidly bad.
It should have taken 5 minutes to half an hour just to get there. Right.
जूम पर स्पेस पे आ नहीं रहा है। हाँ, जबकि जूम इधर ऑन किया हुआ है।
Distinguished guests, esteemed colleagues and friends, it's an absolute pleasure to welcome you all to this hybrid CME on retinopathy of prematurity. We are pleased to have attendees from diverse locations participating both in person and online. Today marks a significant event as we observe the annual ROP week. This initiative is crucial in raising awareness about ROP, educating the public, as well as providing support to families affected by it. By discussing the latest advancements and best practices, we aim to work together towards preventing avoidable blindness in our little ones. Now let's take a moment to appreciate the esteemed panelists who have joined us today. We have with us Dr. Upsham Goyal sir, Director and Consultant Ophthalmologist at TC Eye Care, Lucknow. Their insight will undoubtedly enrich our discussions today. Now let's move on to the ceremonial lighting of the lamp. We invite our distinguished guests, Dr. Oksham Goyal sir, Dr. Aarti ma'am, Dr. Komal ma'am, Dr. Isan Singh sir, and Professor S.K. Gupta sir to please come forward and join us in this tradition. And to invoke the presence of the divine, we invite Dr. Gayatri to mesmerize us with a soulful song.
देखिए इसको इसमें स्क्रीन
Our first speaker for tonight is Dr. Sanjeev Kumar Gupta sir, Professor and in charge of Pediatric Retina, KGME Lucknow, as well as the organizer of this beautiful event. I request our dynamic sir to kindly come on stage and speak on ROP, past, present, and future.
नहीं आ रहा क्या कर सकते हैं उसको कंटिन्यू करेंगे वो ये नहीं आता है इसको करेंगे चलिए कंटिन्यू
I want confirmation from Dr. Manish Tandon at Raj, if you can see my slide.
इनएक्टिव है 50 मिनट वाला तो सही है
Dr. Manish, waiting for your response.
वो तो ठीक है कैप्चर नहीं हो रहा जो वीडियो उनको यूट्यूब पे ब्रॉडकास्ट करना है
कौन कर ब्रॉडकास्ट So welcome all, and this is sort of an orphan topic for ophthalmologists. Orphan, when I say that, I mean that most of us are really not engaged in this particular disease and activity, and also the pharma companies, they have some some contribution to this because they find that this is not a very lucrative business deal for them. So, but however, being an institution and I'm looking after ROP at KGMU, so I feel obliged to perform this activity once in a year. And here we are in the ROP celebration week. We are celebrating this week all around the world, and we are organizing this CME where we'll have distinguished speakers from India, whom I consider are pioneers in ROP as a subject and as a disease. So we will learn from something from them. And my talk is going to be a very superficial touch over the topic, keeping in mind that we have students here and general practitioners who are usually not in depth into this disease. So just touching upon this ROP past, present, future. So as we should touch upon the history just to know that how people have thought about this disease, and anything which has progressed over a period of time needs this reference also, that we can learn, we can also have a insight over finding new things in our lifetime. So it was Mr. Terry who proposed and rather distinguished this disease from retinoblastoma and PHPV. And this is his publication, which is just present and on internet as an image, it is not a PDF. And he marked this finding that it was seen in bilateral disease, which was seen in low birth weight babies, and there was a fibrous tissue just behind the lens. And he could also distinguish that this is not retinoblastoma or this is not PHPV. And initially in 1952, it was thought that this is anoxic or hypoxic injury. But later on, it was discarded. This theory was discarded, and it was realized that it is indiscriminate oxygen delivery which causes. And along with that, it was also realized that rapid withdrawal of oxygen also can contribute. So this is something which we could learn over a fast period of in the era of 1954 or so. So finally, it was concluded that oxygen was a positive factor, and it should be given. And it was decided, rather the guidelines were formulated, that it should be given only when it is needed. And secondly, that it should be duly monitored. So strictly as per the indication, and also monitor oxygen. So this is an interesting image. This is an AI generated image which I put up just to have some attention. So just touching on the classification of ROP, which is pretty complex because we have to talk about so many issues in ROP. So this is a standard diagram which we all have seen and we use, which indicates zones. Zones are basically posterior to anterior extent of the disease. So the theory behind this is that proliferation of the normal retinal blood vessels will start from the disc and will progress centrifugally towards the periphery of the retina. So any cessation or any problem in the progressive development of these blood vessels is going to cause a zone-wise disease, which can be measured from the disc in a radius or a diameter measurement. So we have posterior zone and anterior zone, zone 1 to 3. I'll not go into that detail. And we have clock hours. So it is the anterior posterior extent and also the clock hours, how many clock hours are involved. Then we have vascular changes, and which is graded as grade stages 1 to 5. And basically, it's very easy to remember. Stage 1 is just a line, and a line has one dimension, so it is stage 1. Stage 2 has two dimensions. It has a breadth and a length, so it is stage 2. And stage 3 has some three-dimensional added to it because it is rising up. So stage 3 is a three-dimensional structure, and stage 4 and 5 are basically detachment of the retina, whether retina is macula is on or off, and whether it is whole of the retina which is detached. Now coming to severity of the disease, this basically is directly related to the amount of proliferative factors in the vitreous cavity which cause vascular changes. So we have plus disease, we have pre-plus diseases, and then we have aggressive ROP where they start having shutdown of the blood vessels. So existing blood vessels, even they undergo shutdown. So this is quite bad. So once we have understood that there's some complex classification of it, now coming to how can we detect? Now ROP is a kind of disease which can only be detected by screening purpose. Screening. The reason being that there's a specific window period before which it is not going to be there, after which it is going to be irreparable. And majority, fortunately, majority of the children, they recover on their own. But if we look at that whole scenario, we'll find that they have some ROP and then it regresses on its own. And fortunately, 90% of those who had some amount of ROP will simply regress back. Only 10% would need treatment. So screening is the only way, and we have guidelines for this, which are applicable to region-wise, in the sense that we cannot have extrapolation of those European and American guidelines to India, because we here have different birth weight, different clinical scenario and socioeconomic status. So we should be using the guidelines which are recommended by the experts for our region. So we have Indian ROP Society, which has published these guidelines, and I have also included this QR code, which will land you into a PDF, which will describe these guidelines. And in nutshell, as we know that it is 1500 grams or less children who are neonates who are at risk, but here we have to look for children even more than 2000 grams. So even larger babies who are apparently healthier would also need this screening. And in my screening program, which we are doing at KGM, I have seen even larger babies to have ROP, although there were some other associated factors also. So, and the second variation from the standard screening is that earlier screening may be needed in those neonates who are very, very small. Now, coming to how to screen, we need ophthalmoscopy. Indirect ophthalmoscopy is indispensable for that, and we have imaging tools.
There is no sound.
Which is coming in a big way.
We are not hearing anything.
Okay. It is too late to.
He was already muted.
So can
you hear me now?
Yes, now I can hear. I was not hearing earlier. I think there was some problem with that. Yes, now it is okay. Yes.
Okay.
So can
you see me in my slide, sir?
Oh, yes, now I can see your slide. Yes.
Yes,
So is it
visible, the slide, the screening guidelines?
Yes.
Good that this
my presentation was not so specific and
yes,
was not so important also. But I was just discussing those things about some part of the history and what are the present recommendations for screening.
So
apart from ophthalmoscopy, which is the standard tool, we also have imaging tools now coming up, and we are fortunate that we have Indian versions of RedCam, which are much more cheaper, which can be afforded. Otherwise, RedCam itself is very, very costly for most of us.
And then
we have some biomarkers also. These are also coming up, and we have some research papers will indicate how we can find out that risk for ROP and also risk for severe ROP. So these are also things which we can monitor, and these are the tools which we can use for detecting ROP incidents in these vulnerable neonates.
Now coming to
the management part, and we'll have experienced and very, very well-known figures who will be coming to our talk, and we'll listen to them and know what is to be done. So we have three-pronged approach to management. So one is to promote normal vascularization.
Scarring interaction. This can be done by intravitreal injection of anti-VEGFs. So these are the choice of anti-VEGF molecules, and this will be covered in detail by Dr. Manish Tandon from diagrams. And then we have laser, which is a age-old technique to sacrifice the ischemic retina so as to save the central viable retina, which can give patient good vision. And we had cryo earlier, which has been replaced by laser. So Dr. Mangatram Nungra from Chandigarh PJ will be talking on this and we will cover this topic. And then we have a situation where we have already had a detachment and this will need surgical restoration of the situation and this will be covered by Dr. Subhadra Jilani. And all these three speakers have graciously accepted my invitation to enlighten us with their knowledge. So we'll come to those talks later on. So here at ROP, we are doing some job and we have, this is just an audit of 1 year of data which we are showing here. We have 3 places from which we get these children who are supposed to be screened, NICU and NMU and referrals received from outside. And this includes nearly whole of India. And from January to December 24, we had screened about 627 neonates. And out of that, we found that ROP was present in 150. And we can see that the weight range is larger toward the larger babies, and the gestational age also is towards the higher gestational age. And this is a small glimpse of what we are doing at KGV. Now, I've changed the tone of the background of the slide just to highlight that now we are into the future. So the future of ROP, we all are aware that there is going to be a proposed third epidemic of the ROP going on, and the reasons are that there is greater survival of these immature children, which was earlier not possible. So these are the candidates who are going to develop ROP, and now incidentally they are better able to survive. So earlier these patients are lost, so we couldn't see those ROP patients. Inadequate quality of neonatal care. So this has to grow up, but at present it is not so good. So we'll have those mishappenings happen. And low coverage of ROP screening and treatment service. This is very obvious to all of us. And if you look at the crowd, we can see that there is hardly any interest in ROP. And I don't blame it on the audience or anyone, but it is the nature of the disease itself. It requires a lot of work, a lot of labor, a lot of patience, and it is a difficult branch to practice. Those who do it would know this. Now, there is another problem with ROP, is the fear of mitigation. And this is one very, very discouraging point because I have searched literature and I have found that there is so many literature which have scanned the attorney's office or the law firm's office
and found out ophthalmology में कितना lawsuits हुआ and the maximum amount goes to this. So why would anybody join the ROP screening when they know that there has to be a lot of work, very less reward and penalization. So this is one biggest problem because
the reason is very obvious. There is a very high emotional quotient with the newborn and the handicap of lifelong irreversible blindness is too much to bear. So there has to be some vengeance coming up in the mind of the patient's attendants.
वो डिस्कनेक्ट हो गया 40 मिनट कंज्यूम हो गया
Unless the society, the legal system understands what we are up against,
the bigger problem is that we are just a very small niche. We look at the medical profession as such, we'll find that kind of understanding which we expect from non-medical and general population, it is already not there.
next time when you do it, find a senior Supreme Court and High Court judge that they understand the problem we are facing. Because then they stupid rules and regulations.
Yeah, that is one
Because they are baby and why should we do it? Your baby, not my baby. That's it. It was two heroes who are trying to do this.
Yes.
फिर से लॉग करना पड़ेगा, रिज्वाइन करना पड़ेगा। हाँ मैम, उसी का फीड नहीं आ रहा है। मैं वही रहेगा।
Manish, are you hearing something now? No.
No, I'm not able to see. We just logged out, I guess. We had to log in again, right, sir?
seeing the screen also now. Yeah.
Nothing is visible. No.
Yeah.
I think it was for 40 minutes and they logged out from there.
Yes. Looks like that is the way it is probably.
Should I call him?
I think maybe, I don't know. Otherwise, we are not now.
Okay, sir.
I'll just call him, sir. Kindly
Okay.
rejoin the same link. That is what the message
Yeah.
is on the group.
Okay, rejoin.
Yes.
Okay, we'll leave this and join.
No, sir. Just click on it.
Sir, you
You
are
are
there
there now. I can hear your voice. And it was a technical issue because there is a limitation for that time which we can utilize on the free plans of Zoom. So we are back. And I hope you can see my slide.
I'm able to see your slide. Let sir join back.
So
We are back on track and now we have 45 minutes more.
Wow.
So
I think I'm clear about this, that there is fear of litigation, and that is one reason why we have so many so less people practicing ROP. And more so when we look at the manage, so there are two issues here. One is screening. Screening means that you see, you detect, and you refer the patient to a higher center or an appropriate center. And then there's another issue, managing it. Those who are managing it are doing even a harder job because the outcomes are not very good. The patients, the parents are just not, they don't have enough clue what is going on because they just cannot see the retina and they are not aware of the disease. So they are blindly keep faith in the treating doctor. And again, this is a very tough job for the doctor to have the patient have faith without any visible outcome. They don't see the disease, they don't see the outcome, and they are fearful about that outcome also. And then you have to, those who are like Dr. Manish, Dr. Subhadra, Dr. who are doing surgery for ROP, there's an even more bigger risk. The risk is general anesthesia being given to these small units, which is itself a risky business. So I will personally confess that I have been very much at my back foot to attempt any surgery for ROP for all these reasons. And I can see and I can imagine everybody would be so afraid, and those who are doing it are actually doing a Herculean job.
Yes, ma'am.
So this is the reason why so many ophthalmologists who are good at their job are staying away from ROP. And I'll just give you a clue that at KGMU we are screening more than 600 neonates in a year. And this is being done just by me. Even the screening part is not being done by rest of us. And reasons are obvious. So this phenomena goes on in the whole of our community. We can't help it. So what can be done? Now there are strategies that we can have sensitive and specific biomarkers which can reduce the burden on the ophthalmologist. So there is now presently what we are doing is we are doing indirect ophthalmoscopy, charting out those diagrams and saying that you have ROP and you need this treatment. But if we could have more sensitive and specific biomarkers like birth weight progression and insulin like growth factors, these can actually help us in deciding what to screen and when to treat. So we need these predictors urgently so that we are more confident, and I would say parents can understand and the message can go across, making our job easier. So we can have that. Then there's one more study by Dr. Anand Venikar. It's a kid ROP study, and he has also helped provided as a clue that what can be done to reduce the burden on the ophthalmologist. So this is like tele-screening. So you have technician who is trained in this particular use of camera, red cam or a similar device, and he goes to the periphery, documents this, and this can be sent back. And this will reduce the burden of examining each and every patient under your clinic with all those crises and also the transportation part of these neonates. And this will make the job very easy for all of us. So this is a very well-recognized study from Karnataka, and it has worked wonders. So what we can expect on the front of management is that anti-VEGF may become the first line of choice, and this is my personal belief. I will not superimpose on rest of us, because I feel that anti-VEGF gives the child time for normal vasculature to develop. So it is more like constructive treatment. It adds to the deficiency rather than laser, which is basically sacrificing some retina so that you have the viable central area preserved so that child can see. So I think in coming future we should be having more use of anti-VEGF, and that should become the primary treatment. And we also need newer and safer molecules to come up. I'll not go into that detail, and I'll just wrap up my talk with this AI generated image, which says thank you from a child who probably is obliged and he doesn't know that, he cannot express it, but they need us. And thank you.
Thank you. Very good. Very good. Very nice.
I would like to take everyone's name to appreciate and welcome Dr. Nirama, Associate Professor, Department of Ophthalmology, KGME Lucknow, and Dr. Ankita Singh, ma'am, Assistant Professor, SGPGI, Lucknow, who have joined us as panelists for this evening. Thank you, ma'am, for coming today. Our next speaker is Dr. S.N. Singh, sir, Professor and Head of the Need and Feasibility for ROP screening from the perspective of a neonatologist.
हेलो हेलो सेम है उसमें 2 विंडो चलिए सोर्स चलिए मेरा सेलेक्ट नहीं कर सकते सेलेक्ट कर सकते
Very good evening to all of you, and thanks to Dr. Sanjeev for inviting me. So I'm basically pediatrician and looking after neonatal unit as well. So I'm supposed to talk on need and feasibility of